My name is SHowell, and I would like to thank the Lyon Knee Group for inviting me to speak at their meeting. The title of my presentation is Principles and Verification Checks for Performing Calipered Kinematically Aligned Total Knee Arthroplasty. These are my disclosures. I receive royalties, and I'm a consultant for total knee products with Medacta. What is the definition of calipered kinematic alignment? Well, we use caliper to measure the distal and posterior resections of the femur and also of the tibia. And by doing so, we verify the cuts are correct before we move to the next surgical step. Calipered kinematic alignment restores the patient's prearthritic joint lines and 3 kinematic axes without releasing healthy ligaments. I want to cover that mechanical alignment often changes the prearthritic joint lines, limb, and Q angle, which changes the kinematic axes. The prearthritic knee has 3 kinematic axes that are parallel or perpendicular to these joint lines. So when you change the joint lines, you change ligament lengths. The use of verification checks and caliper measurements of bone resections are able to restore the prearthritic joint lines and kinematic axes. And then finally, the technique is FDA and CE approved, highly reproducible, and simple to perform with a caliper instrument. Mechanical alignment often changes prearthritic joint lines, limb, and Q angle. So let's look at a varus limb. This patient has no arthritis in the right knee. And yet if you look at the hip knee ankle angle, the Q angle, and the joint line, and then on the other knee, and then you were to do mechanical alignment, you would make cuts that would change the hip knee ankle angle, Q angle, and joint lines as you see here. This is the patient's other knee that's arthritic. So when we do calipered kinematic alignment, we want to restore the patient's limb alignment. We want to restore the patient's Q angle. And we want to restore the native joint lines. And when you don't, is when you create the difficulties with stiffness and instability in the knee. Let's look at a valgus knee. Here's a person with a valgus leg with no arthritis. You can see the tibia has a bow about 1/4 of the way down. And there's the hip knee ankle angle. There's the Q angle. There's the joint line. If we were to do mechanical alignment on this non-arthritic limb, you would see that we would change the hip knee ankle angle, we would reduce the Q angle, and we would change the joint line. But this is the patient's other knee. It has a lateral valgus deformity. And you can see that when we do the calipered kinematically aligned technique, that we restore the hip knee ankle angle, we restore the Q angle, and we restore the joint lines, which makes the knee move harmoniously. So if we look at Michael Hirschman's work, you can see that there are very few knees and limbs that actually match a mechanical alignment cut. And he analyzed CT scans of 308 non-osteoarthritic knees. And what he found was wide variability in the distal femoral joint line. 58% of them, the mean, was actually in 3 degrees of valgus to the mechanical alignment cut. And indeed, if you look at all those that are valgus to the alignment cut, it turns out that only 16% of patients that you would do a total knee on actually get a mechanical alignment joint line that's the same as the prearthritic joint line. The rest are deviating more than 1 to 3 degrees. And if you look at the proximal tibial angle, it's the same thing. The mean is actually 3 degrees of varus, and only 30% of patients that you do a mechanical cut end up restoring the prearthritic joint line. So this changes a large portion of the joint lines and the normal knee and in your total knee replacements, which creates the difficulties you see with mechanical alignment. The three landmark studies on knee kinematics that all arthroplasty surgeons should be familiar with are the one by Hollister, published in Core in 1993, where they found the single flexion extension axis in the femur, about which the tibia flexes and extends. The other is Coughlin's, which found a single flexion extension axis in the femur, about which the patella flexes and extends. And finally, the paper by Freeman and Pinskarova that showed the internal-external rotational axis of the tibia passes through the center of the medial femoral condyle and enables a medial ball and socket movement of the tibia on the femur. The prearthritic knee has these 3 kinematic axes that are parallel or perpendicular to the joint line. So what do we do when we do kinematic alignment? We simply resurface the knee. So here are some schematics showing the femur. And the green line is the axis about which the tibia flexes and extends. The magenta line is the axis about which the patella flexes and extends. And the longitudinal axis is the internal-external rotational axis of the tibia that gives you a ball and socket type behavior. So if you resurface the knee, you restore the axes and the resting length of the ligaments. So I like to use verification checks and caliper measurements of bone resections to assemble my knee in a logical sequence that has very high accuracy, and you don't need robots, navigation. They won't compare to the accuracy achieved with the caliper measurements. So what we do is when we make the cuts, as you see here, we want them to equal the thickness of the implant after we compensate for 2 millimeters of cartilage wear and the kerf of the blade, which is typically 1 millimeter. So if we look at an example, here is a right knee. There's the distal medial resection 6, the distal lateral is 8. It's a varus knee, so the 6th resection is thinner than the lateral one by 2 millimeters because of the cartilage wear. And when we add 1 millimeter for the kerf of the blade, it equals 9, which is the thickness of the implant. If we look at the posterior measurements, we want them both to be 7 because the implant is 8 millimeters thick, and here you can see that we've made these posterior resections at 7 millimeters. The error here is less than 0.5 millimeter. In the tibia, we start by measuring the medial and lateral tibial resections, and we would like them to be equal where there is no cartilage wear at the base of the tibial spines. But we then often have to fine-tune the tibial cut 1 degree, sometimes 2 at the most. And how do we do that? We place our spacer block in between the distal femoral and proximal tibial resection, and then we check the varus valgus laxity. If one side opens and the other side doesn't, then we need to take a little more bone away from the tibial side where it's tight. So we're looking for a tight rectangular extension space with no VV laxity, and now we have restored the tibial prearthritic joint line. We check it with trial components, and that verifies that we've restored the patient's limb alignment. We record these measurements on a verification sheet, as you see here, and this becomes the critical determinant of whether or not you perform the operation correctly. Not the x-ray at the end, but the recording of these thicknesses of the resections on the sheet. Calipered kinematic alignment is now FDA and CE approved, highly reproducible, and simple to perform. And this just shows the 2018 FDA approval, showing that it is approved for the GMK sphere and it's safe and effective as predicate devices. Prearthritic joint lines are symmetric, so if we want to compare our outcomes of alignment, we want to try to achieve the alignment of the contralateral side within reason. It turns out the distal lateral femoral angle of 97% of prearthritic limbs are within 3 degrees of the other side. And the proximal medial tibial angle, 95% of prearthritic limbs are within 3 degrees the other side. So that's our target when we do kinematic alignment. We want the one side to be within 3 degrees of the other side. So how often do we achieve this? We wrote this up in 2017. Does the calipered technique restore left to right symmetry of the lower extremity? And this is the distal lateral femoral angle measurement, and this column plot shows the difference between the two sides, the non-arthritic side and the total knee side. And 97% are within plus or minus 3 degrees. So this is more accurate than you get with a robot or navigation trying to get the false target of the mechanical alignment. How about the proximal medial tibial angle? 97% are within plus or minus 3 degrees. This is why calipered kinematic alignment very rarely has tibial component failure, because the joint lines are restored and the knee is balanced without a ligament release. So to summarize, consider trying calipered kinematic alignment total knee arthroplasty. It restores the patient's prearthritic joint lines, limb alignment, and Q angle, whereas mechanical alignment does not in nearly all knees. Calipered kinematic alignment and the use of verification checks co-aligns the axes of the components with the 3 kinematic axes of the knee without ligament release, hence low risk of instability and low risk of stiffness. It's a FDA and CE approved, highly reproducible, and simple to perform. Thank you very much, and if you get to California, up near Sacramento or San Francisco, I'm a half hour to an hour away, please give me an email. We'd love to have you visit and watch some surgery.